Okay, sorry about that, guys. I always forget that with these recording things, you only get a certain amount of time. So we're not too far from the end here. So, along with any kind of pulmonary complications, we always need to talk about PEs, right? So, if we have the big reason we talk about surgery is if you guys remember Virchow's triad over here on the left, we are doing most of these things, right? They have venous stasis because they're not really up and moving during surgery, especially if you're doing an 8 hour long surgery, they have venous stasis, right? Additionally, we are causing trauma, and in general, we're putting them in a hypercoagulable state because we're causing problems and they're trying to fix it as we are causing controlled chaos. So, there that is we are setting them up for clots, right? But we do everything we can to prevent those things. Um, Obviously, you guys know how to diagnose a PE and a DVT. Calf pain, positive Homan sign, PEs, tachycardia, tachypnea, pleuritic chest pain, hypoxia. You guys have already, you've already learned all of this stuff. You're going to treat it. You're going to do your CTA, you're going to do your Doppler ultrasound, and then based on whatever happens in their hemodynamic stability, you're going to move forward with treatment. But in the surgical world, we don't want it to get to this point. So what we do is we do everything we can to prevent these. So you'll see this on an inpatient side of things from hospitalists, but almost all surgeries, unless they're really short, like ENT surgeries or like a carpal tunnel surgery, the patient's going to get these things called SCDs. They're called sequential compression devices, and they are I call them massagers to patients because I think that sounds more pleasant than things that will squeeze your calves really tight. But they're basically things you wrap around people's lower legs, and they intermittently basically compress the calf to mimic the walking motion to help with blood flow in the legs. Additionally, a lot of patients, especially if they're inpatient, they're going to be there for a while. They're usually put on some kind of VTE prophylaxis, such as Lovenox. From an ortho side of things, there are a lot of different things, but for the first month, I know my surgeon always put patients on aspirin 325 twice a day for the first month for knee replacements and hip replacements because they're not walking as much. But there are a lot of people who do Lovenox or Xarelto or whatever it might be that needs to happen. Additionally, if you've got a patient that is on warfarin for AFib or they've got factor 5 or whatever it might be, they might need an IVC before surgery just to prevent PEs. That's obviously not your decision. You tell them to talk to their cardiologist or their hematologist about that. And then again, if I can't hammer it home enough, these people should be getting up and they should be moving. They should be walking as soon as possible in order to prevent clots, because as we know, getting up and moving is one of the best ways. Staying static and sitting down is is a surefire way to get a DVT postoperatively. All right, so let's skip a slide there, did I? No. Okay, so postoperative bleeding. This is something that we see hopefully infrequently, but in general, from a postoperative bleeding standpoint, if it's significant, it's unfortunately due to a lack of hemostasis in the OR. So there are times, though, that you just can't prevent it. People that already have preoperative thrombocytopenia, if they've got liver dysfunction and they're not making platelets, if they were on warfarin pre-op and then you have to start at post-op day 1, then you have risks of bleeding from your surgical site. Obviously, if they are hemophiliac, you're going to probably see some bleeding post-operatively. There are a lot of ways in the OR. This is one of the reasons I love the OR. It's just so many different ways to do things, different ways to help your patients while you're in the operating room to decrease problems post-operatively. One of them, the very first one, probably the most important one, is electrocautery. So you can see over on the left here these little yellow pen things. These are called bovies, and what it is it's a utensil used in the operating room that provides electrocautery so that you can cauterize bleeding vessels. Obviously, you're not cauterizing big vessels like, radial artery or things like that. But small venous drainage, arterial drainage into your surgical site, you want to stop those things not only so that you can see what you're doing intraoperatively, but you want to make sure that when you're closing, you're not bleeding a lot, because you're going to bleed right through that incision and you're going to be back there soon. Back in the OR soon. So this is a great tool. You see it in tons of operating rooms. There are some topical things you can use. Like I've seen a fibrin gel. Basically, you're rubbing that around this inside the surgical site to basically help with clotting. Blood salvage. This is one of my favorites from a cardiac standpoint. So when you're in the operating room, you have your standard suction tubing that's used just to get out extra fluids. But for cardiac patients, because they bleed so much during the procedure, we have a special suction tubes that are specifically for getting blood. And so we put them, usually you bleed into the cardiac cavity, and so you put these suction tubes down into that area, and what they do is they pull out the blood and they put them into this machine, and it cycles it down. And what it does is it takes that patient's own blood and it filters it and then packages it into a packed red blood cells. And so then you can actually retransfuse that back into the patient. So I believe this is used in trauma surgeries as well. It's a great way to help control bleeding, but also give them their own blood back if they need it. Another thing, antifibrinolytics. So in ortho, I saw a lot of TXA, tranexamic acid. And so what that is it basically, you can either give it orally or you can put it in liquid form on top just to help decrease bleeding. When we're talking about postoperative bleeding, getting a CBC post-op day 1 for high-risk surgeries, aka if they've been admitted, then that's usually good because you want to make sure that they didn't drop 3 points, right? It's always good to have a pre-op CBC too, so that you know if they were already sitting at 8 beforehand, then they're still there. But in general, transfusion depends on the specialty, but the general rule, if it's less than 7 or platelets less than 5,000, you're going to transfuse. So hemoperitoneum, this kind of goes along with the lack of hemostasis. This is the most common cause. This is usually in abdominal surgeries, and if you have someone go into shock within 24 hours of an abdominal surgery, you need to be thinking hemoperitoneum. As you can see on the CT scan, there's a lot of blood in the abdomen, and that is not what should be happening. The problem is that these patients go into shock because they all of a sudden have it's hypovolemic shock, right? They're tachycardic, they're hypotensive, they're not peeing, and it's because all of their volume, they have all of this extravascular volume and no intravascular volume. And so these patients can get these like increase in their stomach size. They can even get an abdominal compartment syndrome. You can diagnose these with CT. Obviously, now that we have very skilled people from an ultrasound side of things, this would be like having free fluid in the abdomen, and the treatment is almost always reoperation to evacuate that fluid, obviously resuscitation of their intravascular volume, but you need to find the cause of the hemostasis or cause of the bleed and achieve hemostasis. Ileus, this is super common. We expect this to some degree with all surgeries. A lot of times it's just because people are taking postoperative opioids for pain control. But it's more common with abdominal surgeries if they have perioperative complications as well. If they're diabetic and they have gastroparesis, it can happen too. The big thing with this is if they have true obstipation, you kind of need to step in. So obstipation is they're not pooping and they're not having gas, right? So that's an important thing for me as I am rounding on my patients. I always ask, have you had a bowel movement? If they say no, that's okay. If they're still at like day 3, but I say, are you passing gas? And if they say yes, then I'm a lot more comfortable with that. And most of them are. But if they're not passing gas and they're not pooping, and there's like, man, my stomach hurts, I can't eat anything, those are the times you need to start kind of being like, I might need to intervene here. Plain films are totally fine for this, for diagnosis. You'll see these really uniform bowel loops, and there's no transition zones, which is important because if we see a transition zone, we're thinking more bowel obstruction. So depending on the surgery and the type and length and severity of the surgery, typically more than 5 days, we need to really kind of start thinking about what can we do for this patient. In general, though, they all end up pooping by day 3. So some of them will say, though, well, I only poop every 5 days. So you don't need to start jumping on them if they haven't pooped at 3 days, post-op day 3. But in general, we do bowel rest. We don't give them, we're doing liquids, not solids at that point. We give them, nausea medications. We start doing some big things like lactulose or enemas to basically get them to poop if we really need them to. Bowel obstruction, obviously, this is a huge deal, even not in the post-operative period. But for this, it's really important because in general, these have a delayed diagnosis because of the time frame. And so that can lead to a high mortality rate. That's 15%. And the reason it's delayed is because the bowel obstructions typically are coming after abdominal surgery, and it's because they're forming adhesions, right? So full-blown adhesions really take about that 4 to 6 week time period. They're usually mature at about 6 weeks. So these patients are doing fine, and then all of a sudden they start having problems. And so that's why it's really important if you are doing general surgery type stuff or abdominal surgery to think about this if you have someone kind of complaining of additional problems in that 4 to 6 week time period. And again, the difference here, you will see dilated loops of small bowel, but you are definitely going to see a transition zone because of that obstruction. So that's something to be looking for on your abdominal x-ray. These people typically nasogastric suction. If they have a true bowel obstruction, you kind of have to evaluate, are they hemodynamically stable? And can we keep them stable, right? Because in general, you don't really want to go back in the 4 week time period because you want to go back in when the adhesions are mature because otherwise you could be causing more problems. So trying to keep them stable for 6 weeks. Obviously, if they are unstable, then you go in sooner. Fecal impaction, this is almost exclusively in your elderly, could be in kids too if you are working with children who already have this problem. In general, they just have a colonic ileus. They don't really want to eat. They can get obstipation or they can even have diarrhea. So you need to be thinking, well, if they're having like smears or liquid, they could have a fecal impaction, right? Because as you guys probably remember, it can go around the solid stool. Diagnosis, digital rectal exam, you could probably get abdominal x-ray as well and see that colonic ileus. In general, I would say manual removal is not nearly as common as people doing enemas because no one really wants to do a manual removal, but sometimes it is necessary. Post-operative urinary retention, I love the occurs in 5 to 70% of patients. What a range. I will say that in general, these are going to be your older males who already have history of urinary retention. There are times people with like MS and stuff like that can get it. But in general, it's your old men who already have a history of urinary retention, getting a joint replacement, who had a spinal, and they also had a scopolamine patch because they get post-operative nausea. It's like every patient that I've had that's been the case. I mean, there are other things that can contribute, but those are just, it's going to be your older men who already are probably on something like Flomax. These people, they have pelvic fullness. They do, they feel like they need to go, but they can't. They'll tell you that. True diagnosis is 600 plus milliliters of volume on a bladder ultrasound. And generally, you're going to IO cath these people or give them a Foley. But in general, we need them to be able to spontaneously pee before they go home. So that's an important thing, is making sure that you try at some point, because you can't send them home with a catheter unless you have like a urology consult and they're cool with that. But in general, you probably need to try IO cathing, see if that helps and calms things down, get them on Flomax or something like that to help them pee. So CVA, the interesting thing that really kind of distinguishes CVAs in a surgical world is that they're almost all ischemic. And the reason being is that as you're doing surgery, you get volume loss. And then, if you get hypotensive, then you can have poor perfusion to the brain. So we're not talking about like a hemorrhagic embolic stroke. It's usually ischemic. It's most commonly in your elderly patients because they are more commonly have carotid stenosis. And so these are, more common with your carotid endarterectomies, open heart surgeries, emergent surgeries where patients could have high volume loss with a drop in their pressures. But in general, risks in other surgeries is pretty low. Obviously, if they already have a history of cerebrovascular disease, they're going to have increased risk. The big thing is if you have poor perfusion, meaning low mean arterial pressure, then you can have irreversible damage from that ischemia at 4+ minutes. So that's an important thing to be thinking if you do have a drop in pressure during a case, to make sure that you can get it back up. I will say this is 55 for your mean arterial pressure. In cardiac, we say 60 because we do have that higher risk of having this type of complication. So we try and keep our MAP above 60. That's just something that you need to be watching. This is where like good communication between anesthesia and the surgeon and all of the surgical staff is important, because everyone needs to know if the pressure's dropping. We need to figure out why. We need to get them on the right medications. We need to be really, we need to be transfusing. We need to be giving them LR, whatever it might need to be, because it's a team effort on this one. So with seizures, in general, the most common people who are going to have seizures are people who already have seizures, right? So your epileptics. If there are metabolic changes within the case, that can increase your risk of seizures. Interestingly enough, patients with UC and Crohn's do have an increased risk of seizures. Don't ask me why. I don't think anyone knows. Last I read, they were still trying to figure this out. But that's just I thought that was an interesting fact. So something to think of if you have a patient with that. The big thing here is you need to resolve their seizure as fast as possible, mainly because of the harmful neurologic effects. But additionally, think about the surgical site complications if someone's having a grand mal. You could rip open their incisions. Big thing for me when I was in ortho, we did a lot of shoulder surgeries. And so, as you guys probably remember, a lot of people when they're having grand mal seizures dislocate their shoulders, right? That's not ideal for having just fixed a shoulder, is for a shoulder to dislocate. So those are important things for us. Prevention, you really want to make sure that these patients are not frequently having seizures. I think most guidelines is that you don't want a grand mal within 6 months of an operation, because anesthesia does lower the seizure threshold. And so you need to make sure that they're stable on their current medications and not having a grand mal every week, because most likely they'll have one perioperatively. For your epileptics, you definitely want to make sure that they are taking their seizure medications the day of surgery, because they have to be stable, right? If that's what they're stable on, they need to make sure they're still taking it. And as you guys know, a lot of those seizure medications do require blood level testing, or they're very finely tuned, and you don't want to really be messing with that. Additionally, utilizing other types of anesthesia. So like we talked about earlier with doing nerve blocks, so that they don't have to have as much gas and those types of things. From a psych perspective, I will say postoperatively, most people who get psych problems are either those who already had them beforehand, or elderly patients. The most common one is going to be delirium for sure. This is usually at about post-op day 3. They just really don't know where they are. They don't know the date. They get confused and a little bit fearful as well. Another one is ICU syndrome. So what this is, and this happens not just from surgical things, but this can happen even if someone's just in the ICU for something else. But for those of you who haven't seen an ICU, basically most of these people are intubated. They're on a bunch of machines that beep loudly all the time. It's very bright in there. A lot of them have windows, but some of them don't. So they get this kind of like altered reality, and they don't sleep well because it's loud. And so what they've actually done is they've done a really good job transitioning this. In our cardiac ICU, it's dark at night, it's quiet at night. They do everything they can to minimize these types of things so that patients can get good sleep, and then they don't have to go into this kind of ICU syndrome type thing. This one is really interesting. It's called post-cardiotomy delirium. Usually happens about post-op day 3 after open heart surgery. I'm not sure that they know exactly what causes this, but again, most of your patients day 1, day 2 are in the ICU, so it could be related to that. But if they're really having problems, if they're really delirious and they're trying to get up, they're trying to move, they're trying to push themselves up out of their chairs, they've got a sternum that's been cut open recently that if shifts, it could tear apart their bypass grafts, which is a big deal. So you need to put these people, probably not put them down, you need to get them to settle down, right? So give them a little bit of Haldol to kind of calm them. Delirium tremens, this is obviously typically with your alcoholics. And a lot of this is probably comes more, if you're doing elective cases, you're asking these people about their history before you even schedule them, so you can start them on CWA protocol when you admit them. But think about the cases where you have a patient come in, they were found down, they need, they had a aortic dissection, and here you are, you fixed their aorta, they're post-op day 3, and all of a sudden they're not acting themselves, they are confused, they're hallucinating, they're starting to have tremors, and then they go into seizures because you didn't know that patient was having a pint a day, right? So, those are the things you need to think about, and as soon as you can, ask these patients, or just ask them to be honest with you, because that can be a problem if people start, going into DTs. So I'm going to hit on postoperative wounds really quickly, because I know Olivia kind of talked to you guys about that yesterday. But hematoma and seroma, these kind of are grouped into a family. So basically what these are fluid collections in your surgical site. So hematoma obviously is going to be a blood collection, whereas a seroma is more like serum or lymphatic. It's just anything that's not blood or pus, okay? So for hematomas, they're typically due to lack of hemostasis, especially in those who are on anticoagulation. And then with these, unfortunately, is this pocket of fluid, and bacteria love to find pockets of fluid. So these patients typically have increased risks of surgical site infections. These are usually pretty obvious because if they have one, they're usually pretty big, or you can kind of feel them. They get this swelling in the site. They're uncomfortable because their skin usually gets pretty taut. It can be discolored, kind of look like a bruise if it's a hematoma. But most importantly, you might start seeing drainage or seepage from the incision. That's a problem, right? That means that there's enough fluid in there that it's coming out of your incision. Most likely those areas of the incision that it's draining from aren't healing. If it's a small one, you can, they typically go away on their own if they're smaller. I have done a few in-office evacuations where I'm just kind of squeezing, because it kind of feels almost indurated, not in a infected kind of way, which is a little bit hard. And you kind of squeeze that. I've done some hematoma evacuations that I can squeeze through areas of the incisions before I take out the sutures, so we can leave them in so they heal afterwards. But it comes out, this might be a little graphic, but it comes out looking like grape jelly from hematomas. So those are fun from my perspective. Large ones, though, if you've got a really big one or it's causing a lot of pain, you might have to go back to the operating room to evacuate that. And at that time, you can either close it up if it looks good, the tissue is safe and enough to close, or sometimes you need to do, pack it and delay and go back later and reclose it. Wound dehiscence, this is such a big deal in the surgical PA world, all right? And I'll kind of explain why. But what this is basically when you're closing, you need to make sure that you're closing your deep layers and then your superficial layers, because wound dehiscence typically comes from a disruption of the deep layers of your closure. This happens in 1 to 3% of abdominal surgeries, and the problem is, especially for the abdomen, if your deep layer comes apart, it can then come through your superficial layers, and all of a sudden you have evisceration, and someone's sitting there in your office with their intestines sitting in their stomach. I will never forget, it didn't happen to me, but I saw a patient, I was talking to them because they wanted to have surgery, and We were talking about their past surgeries, and they told me that happened to them. They said that something just didn't feel right, and they went in to see their surgeon, and by the time they sat down, they eviscerated. They were sitting there in the office, they had eviscerated. And that's a big deal, right? Because that carries a 10% mortality rate because their organs are sitting on the outside of their body. So that's a big deal. Occurs usually post-op day 5 to 8. And generally, these people are going to have some kind of serosanguinous drainage before total disruption of the wound. Risk factors for patients. Obviously, this list, pretty much covers all of our patients that don't heal well, probably renal patients who probably have these problems anyways. But obesity is a big one, especially for the abdominal one, because it increases the abdominal pressure. So what are the local risk factors, right, versus systemic risk factors? So wound closure is the number one contributing factor, and that's why it's such a big deal in the PA world. When my surgeon steps away from the table to go do his operative report, he trusts me to close those fascial layers. And since those are the strongest ones, I need to make sure that I'm getting good reapproximation. I need to not be taking too small of bites. I need to be grabbing enough of the tissue, because otherwise the suture can just rip right through, and that leaves vulnerable areas to dehiss. Ways to avoid this: using enough sutures, not skipping a bunch of tissue, not rushing, making sure that this is truly securely closed before you move on to your next layer. Type of suture for this part, for the deep layers, are important. I typically use heavy Vicryl or a polypropylene suture on infected wounds. Another thing to think about is if you're leaving a large dead space afterwards, you might be able to put, like if your wound is dehiscing because you have a large hematoma or a seroma, you might be able to put in a drainage tube at the end of surgery. We did this a lot with our bursal excisions. If we were doing bursal excisions that were infected or inflamed and left a large pocket, we would put a drainage tube in connected to suction to allow that incision to heal and allow that area to drain so it just didn't build up. So another one, increased abdominal pressure. We kind of talked about this with the obesity, but obesity is a big factor. COPD, coughing, ileus, all of those things increase that abdominal pressure, which for abdominal surgeries can cause wound dehiscence. And then in general, just poor wound healing. As we already talked about, the people that don't heal well. But when you start to see your incisions around the incision at about day 5 to 7, there's it's called a healing ridge, but it's you can feel that it's like, it almost feels like scar tissue. It's a little bit harder, but your incision doesn't look infected. But when you have poor wound healing, that is not there. So that's something just to consider. Again, it's just most commonly in your poor healing comorbidities, but unfortunately, because of that, infection is common in about 50% of those cases. Speaking of wound infection, this is going to be real brief because I know Olivia covered this in detail. It can be deep or it can be superficial. If you had a clean wound, your infection rates are going to be lower. If you had an ATV accident with a large leg lac and a tibial fracture, like a open ankle fracture, whatever it might be, in the woods, then you might have a higher risk of wound infection. And then again, these people, they have redness, pain around the incision. They could be indurated, fluctuant. They could be having active drainage from their incision. It's usually purulent, if so. Treatment in general, if you're having gross discharge from your incision, probably not. You might need to take them back to the OR, do irrigation and debridement. I generally try to catch these early, especially when I was in ortho. I usually put them on PO antibiotics for a week and saw them back a week later. I usually did Keflex. If they had a penicillin allergy, I did Bactrim. My diabetics or anyone who had risks from MRSA, I usually jumped directly to Bactrim. You can use Clinda too. There are lots of options. I would just defer to what your surgeon typically likes to use. As far as an irrigation and debridement standpoint, going in, cleaning out the infection, changing hardware if you need to, and then deciding whether or not if you want to close it then and there, or if you need to do a delayed closure, maybe do a wound vac on those things. So all right, almost there. So This patient, black male, history of hypertension, hyperlipidemia, type 2 diabetes, presents to the PACU, so the recovery area, after total knee replacement. Before you leave, you notice the patient becomes hypotensive. You see the following rhythm on the telemetry. What is the most likely cause of this new rhythm? Now, for those of you that don't, I know Stacy taught you this. I know your EKG class taught you this. But the biggest thing is to recognize, if nothing else, that this is not normal sinus rhythm, right? It might be a regular rhythm, but there is complete dissociation between the P waves and the QRS. So that's important to remember. This is not normal sinus rhythm. Typically, PEs don't cause this. Atelectasis is not going to cause you to have complete heart block, and usually a CVA isn't either. So remember, any new arrhythmia in a pre-existing cardiac disease patient, right? And this guy, he doesn't have noted coronary artery disease, but he's got hypertension, hyperlipidemia, and type 2 diabetes, all of which are associated with coronary artery disease. So you need to be thinking MI in this patient. So this patient is a 45-year-old male. He has Marfan syndrome. He's post-op day 1 after thoracoabdominal aneurysm repair, which, if you guys don't remember, people with Marfans get aneurysms. While rounding, you see that his oxygen saturation is 92. He's on 2 liters normal cannula, or nasal cannula, and his white count's a little bumped. So what would be the most likely cause of his respiratory status? So the first thing I will say, and I'm sure you guys have talked about this, but people after surgery, right, you're putting a lot of stress, especially big surgeries like this, you put a lot of stress on them, so you get what's called reactive leukocytosis, meaning that you can have a little bump in the white cell count without having an infection. The guy is post-op day 1. It's completely acceptable for him to be on 2 liters nasal cannula, good for him, and be satting at 92%. We'd probably up it a little bit to get him up there, probably put him up to 3 or 4 liters just to get him up a little bit on his oxygen saturation. But in general, he's post-op day 1. The likelihood without an aspiration event of him having pneumonia at this point is lower. Pulmonary embolism is also low. It's not going to cause a... he's not tachypnic or anything like that, right? He's doing okay. He likely does not have an aspiration event, and so you need to be thinking atelectasis at post-op day 1. For those of you that don't know, thoracoabdominal aneurysms are done through a ginormous thoracoabdominal incision starting on the upper back, extending all the way down around the left side into the abdomen, which is an awesome incision. But they actually completely deflate the left lung because they are they have to work on the aorta, which is right there, right? So these people frequently have atelectasis post-operatively. But again, you're thinking post-op day 1, the first thing you should be thinking for someone who has lower oxygen saturation is atelectasis. So obviously, this is pre-recorded for you guys. Sorry, because I didn't know how my Wi-Fi connection would be. If you have any questions, though, feel free to email me at this email. I'm open to chatting. If you guys had specific questions anytime, just let me know. There are my references. So thanks so much, guys. I appreciate your time. Sorry that was a little bit long, but hopefully I get to see you guys intermittently over the next year as you guys kind of grow as PAs. So thanks.